Good morning, everybody. We're going to get started. Welcome to our grand rounds and annual pediatric urology visiting professor. We have to start by saying this conference is accredited for CME by the Yale Medical School. There are no commercial sponsors for this conference. Disclosures were reviewed and no conflicts of interest were found. So I have known Vijay since fellowship when we did a laparoscopic course together. And I was very excited because at that point, everyone's kind of on the same trajectory and kind of going the same direction. And I can tell you as I reflect now 15 years, I shouldn't say 10 years back, our courses have very diverged. And I think she was professor when I was still assistant professor. So I'm still hoping to catch up, but I think the angle of rise is a little too steep for me. But she is now currently at University of Colorado, where she's professor of urology. She's the program director. She's the chair of the Fetal GU Anomalies Working Group. She's director of research for urology. She's led a task force for the AUA for diversity. She's done the same thing for the Society of Academic Urologists. She's won more awards than I've applied for. And she is clearly a rising star in urology. In fact, has gotten a Rising Star in Urology Research Award through the AUA. So again, a CV that's more impressive and hard to compete with. She started her course in Mississippi, where she then went off to college in DC at George Washington, then went to Harvard Medical School for her law degree, where she met with some soon-to-be Supreme Court justices. You can guess her age to figure out which one she was in school with, but I think they still do holidays together. She then went to medical school back in Mississippi and followed that with residency at Baylor, where she worked with another very preeminent urologist at the time, and I think they still share some holiday cards every year. So she trained with Dr. Kim, who we all know here very well at our program. After Baylor, she went to Wash U, and then eventually back to Colorado, where she's been now leading pediatric urology research. She's the research director for the Department of Urology, has the Fetal Anomalies program we talked about, and is going to talk about some of this today. So I'm very excited to introduce Vijay. She's going to give a excellent talk this morning, and I get to spend the day with her trying to stump her on some clinical questions.
Thank you so much, Dr. Kittleman, for that wonderful introduction. I'm just going to talk a little bit about some of the work that we've done in our fetal center. I do want to disclose that we are a participating center in the RAFT trial, which I'll briefly discuss in this talk. So antenatal hydronephrosis, I think most of you know, is one of the most common screening anomalies that we find prenatally, affecting up to 5% of pregnancies. And it represents a very wide spectrum of conditions ranging from transient hydronephrosis in utero to significant upper or lower tract obstruction that can be associated with renal dysplasia, renal dysgenesis, or in utero renal failure. And so when we look at sort of when we do prenatal intervention, our primary goal is really to focus on pulmonary development. It is not to necessarily improve renal outcomes or bladder outcomes. Before we sort of talk about the sort of roles of fetal intervention, I do want to just bring up that we are in kind of a watershed moment in terms of what we're able to do and how we consider the fetus under the law. As most of you guys know, in 1973, the Supreme Court found that there was a right to abortion based on maternal right to privacy under the 14th Amendment due process clause. And this sort of led to this idea that the state had to have a compelling interest in potential life that was not considered compelling enough to allow for regulation until after viability of the fetus. And as a result, that state interest did not outweigh maternal sort of preference in this situation and did not outweigh the risk to actual life or health of the mother even after viability. Viability sort of has been this very kind of loose quasi-medical term and was defined in two Supreme Court cases, Planned Parenthood versus Danforth and Planned Parenthood versus Casey, as the stage of life where the fetus may have their life continued outside of the womb by either natural or artificial life supportive systems. This has historically been considered to be around 24 weeks. However, as technology has improved, we have seen that viability might be earlier, and it might actually vary based on what hospital you're at and what sort of experience your providers have with premature infancy. One of the other things that's important is from an ethical standpoint, you are able to consider the fetus as a patient. That does not automatically infer that the fetus has independent standing as a person, And so as a result, the thought is that in terms of fetal intervention decisions, the mother can determine care and can withdraw status in terms of the fetus as a patient at any time prior to viability. However, this summer, the Supreme Court reassessed their sort of decades of precedent and found that there was no constitutional right to abortion under the Due Process Clause, and that pregnancy was not sufficiently associated with gender to warrant increased protected status under the Equal Protection Clause of the 14th Amendment. And as a result, the state's interest in preserving fetal life only needs a rational basis when looking at regulation. And there's also been sort of this theme through the court of a shifting interest towards fetal personhood and independent recognition under the law. This has been seen in sort of prior history of both state and federal feticide laws, where loss of a fetus due to injury can be considered a criminal action. And we've already seen places where states have actually prosecuted mothers for injuring their babies under feticide laws. This sort of new change has kind of really led to questions about fetal status and what can be done in terms of our medical practice, whether it looks at things such as in vitro fertilization and reduction of embryos, either at the time of implantation or discarding of embryos that have not been implanted. There have been cases in multiple states, including Texas, where there are concerns about delay of care or lack of care for ectopic pregnancy and miscarriage due to the sort of conflation of D and C for abortion for other therapeutic causes. There are questions about whether we can offer mothers abortion in cases where they might need chemotherapy for cancer or other treatments that might put their fetus at risk. And it's still unclear that, based on a state by state basis, whether interventions that are meant to sort of promote fetal life and well-being, but have a high risk of preterm labor or miscarriage, may actually also be considered potentially criminal under sort of new state laws. So more to come on that. With that being said, I just want to talk a little bit about some of the diagnoses that we see in our fetal program and the ways that we approach them with some sort of, I would say, representative cases. So posterior urethral valves occurs in somewhere around 1 in 4,000 to 8,000 male births. It is the most common lower tract anomaly that we see, and it accounts for about 10 to 12% of prenatally diagnosed urologic pathology, but is responsible for about 1/3 of cases of end-stage renal disease in young children. The sort of classic findings are a male infant with bilateral hydronephrosis, oligohydramnios, and a keyhole sign with the bladder and posterior urethra dilated as seen in this picture. There have been studies that suggest that brightness of the kidneys have moderate sensitivity and specificity for associated renal injury and may be in part predictive of renal insufficiency after birth. We use a fair amount of fetal MRI at our center, and fetal MRI has several advantages in cases like this. It provides improved evaluation of ureteral anatomy, renal cystic changes of the kidney parenchyma, and as seen here can kind of help delineate urinomas or other sort of extra bladder, extravesical sort of urine leaks in the abdominal cavity. And we utilize fetal MRI in cases where low amniotic fluid levels, maternal body habitus, or fetal positioning may limit adequate assessment of the urinary tract, as well as if we are concerned about other anomalies, including neurologic, pulmonary, or cardiac anomalies associated with the diagnosis. So this is the first case I want to present. This is a 37-year-old G2 para-1 female woman who was noted at 19 weeks to have a male fetus with bilateral hydronephrosis, ureteral dilatation, and oligohydramnios. They came to our center to discuss potential options for care, and the options that we discussed with the family included termination of the pregnancy, comfort care or observation during the course of the pregnancy with the anticipated early neonatal demise, or placement of a vesicoamniotic shunt. When you think about what sort of the natural history is of doing nothing, we know that these babies tend to have a high rate of intrauterine or neonatal death, with about 20% of babies not surviving to term, and about 50% of these babies not surviving in the neonatal period. There's also been studies that suggest that earlier diagnosis of posterior urethral valves is associated with a poorer prognosis, with less than 25% of infants surviving after term if they're diagnosed in the first or second trimester, and the majority of infants who are diagnosed late having at least 1 year survival. we consider sort of the reasons for fetal intervention to be threefold. One, you want to make sure there's evidence of bladder outlet obstruction that could be due to sort of upper tract dilatation, a full bladder. You want to make sure that there's evidence of reversible renal injury or at least sufficient renal function to produce amniotic fluid throughout the pregnancy. Traditionally, we have utilized fetal biomarkers to assess this, as well as some sites will actually do a therapeutic vesicocentesis to drain the bladder and see if urine reaccumulates as another sign of renal function. And finally, you want to intervene in the period of time where lung impairment may be reversible, which is considered to be 18 to 26 weeks. This is just a sort of schematic of what have been traditionally utilized as prognostic values for determining renal function. The most sensitive of these is beta-2 microglobulin. However, these are relatively good predictors in looking at the likelihood of having fetal urine production. Several studies in pediatric urology have demonstrated they are not great predictors of long-term renal function postnatally. So in our case, the family chose to pursue vesicoamniotic shunting. They had not had a pre-procedure vesicocentesis, so we did not have electrolytes that were obtained prior to the procedure. However, they did undergo amniocentesis, which showed no evidence of chromosomal anomalies. And we'll talk a little bit more about why genetic testing might be important in some of these cases. When we look at sort of the outcomes of vesicoamniotic shunting, there's only been one randomized controlled trial. This is the Pluto trial, which was conducted in Europe. The primary outcome of this study was 28-day survival. And they really had difficulties with recruitment because they could not find sufficient numbers of women willing to undergo the intervention. So the numbers were relatively low in this study, but were relatively equally distributed between intervention and observational groups. The study utilized an intent to treat analysis, and they found that babies who had undergone vesicoamniotic shunting had a higher 28-day survival, 50% survival versus 25% in the unshunted group. And all deaths in this 1 month period were due to pulmonary hypoplasia. They also found that 1 year survival was increased 44% versus 20% in the observation group, but neither of these survival numbers were statistically significant, and that's likely just due to the low numbers of the study. Because of the low numbers, they were not able to really make any meaningful conclusions about the impact of shunting on renal function. However, based on the descriptions of the patients that did survive to a year, there seemed to be more patients requiring medical management or dialysis in the unshunted group compared to those patients that were shunted. One of the other things that people have looked at in terms of prenatal intervention for these patients is fetal cystoscopy. And the largest series that has been done is by Ruano et al., looking at 111 fetuses, 34 of whom underwent fetal cystoscopy and valve ablation. The thought is that by treating the valves in utero, you're able to sort of re-establish normal bladder cycling. Voiding pressures are thought to be lower than pressures of drainage across a vesicoamniotic shunt. So there's a theoretical benefit to kidney preservation as well in this situation. So in this series, they found that survival was, 30-day survival was improved with a survival rate of 40% versus 20% in the observation group. And they also found a trend towards improved renal function. However, this did have a pretty significant complication rate. 10% of their treated infants had urethral fistulas, and they had 2 babies that had recurrent bladder outlet obstruction in utero that ultimately died at birth. That have been done. There's been about 10 studies over about 28 years with about 355 patients, and they show that there is an increased survival benefit that is statistically significant in patients that undergo prenatal intervention, and that these numbers are actually similar with fetal cystoscopy as well in terms of 30-day survival. And so the top graph is shunting survival, and then the bottom is for the cystoscopy. And they also, again, found a trend towards improved renal function, but this is not statistically significant. It's important to know that these are studies that oftentimes utilize fetal electrolytes in terms of their selection criteria. So there may be a selection bias in patients who were observed versus underwent intervention. So in our case, we did place a vesicoamniotic shunt, which you can see with the coil here in the bladder. However, 1 week later, so at 21 weeks, the baby became anhydramniotic. And so then we had a second family conference to discuss options of care. Again, we discussed termination of pregnancy, which is legal in Colorado at any age, comfort care, or serial amnio infusion for lung development. So serial amnio infusion has traditionally been utilized when there's been mechanical disruption of the membranes and loss of amniotic fluid. However, as early as 1994, there have been case reports of using amnio infusion to promote lung development. And these studies have shown relatively good early postnatal survival, but very few have had long-term outcomes. More recent case series with longer follow-up have shown that there's a very high mortality at 1 year, with a series from 2020 and a series from our institute at 2022 showing upwards of 75% 1 year mortality. And in our series, only one patient survived to an age to be eligible for transplant. And I think one of the things that this sort of intervention raises is the question of what is surgical innovation versus what should be considered research. And so when we think of the definition, generally surgical innovation is considered to be tweaks to a established technique as opposed to a significant departure from what's considered current accepted standard of care. And the purpose of an innovation is really for improvement of an outcome for a specific patient. It is not to create generalizable knowledge or sort of shift what the standard of care writ large should be. One of the concerns is when you have a treatment like amnio infusion, how do you really adequately counsel a patient when there's no data about long-term efficacy? And there are also concerns about families sort of understanding the sort of uncertainty of these outcomes. There's what's called therapeutic misconception, which is that many patients think that something that's new by sort of definition is better. So even if you try to counsel regarding the unknowns or about clinical equipoise, they tend to go for the newer treatment. And the other concern is by offering these sort of as one-off cases in multiple practices, there may be a potential chilling effect on actual formal research to more rigorously track outcomes in these babies and assess what the efficacy of these treatments really are. So similar to the MOMS trial, which established a moratorium on fetal myelomeningocele closure outside of a research trial, the RAF trial, or the renal anhydramnios fetal therapeutics trial, was started, I believe, in 2018. The goal of this was to utilize serial amnio infusion in babies that either had in utero renal failure or bilateral renal agenesis, to see if it could improve pulmonary survivorship. And so the primary outcomes were 30-day survival as well as survival to renal transplant. And patients are excluded if they are outside of the 18 to 26-week window, if there are significant other anomalies of the fetus, or if there are significant maternal comorbidities that may impact the pregnancy. And so when we think about how we consent patients for studies like this, I think it's important that at least traditionally, this has been something where the mother is the one that consents prior to viability. And we talked about why that was under the law. This may be an area that is in flux given changes in sort of legal status of the fetus with recent cases, and may end up being something where state by state, the interests of the fetus may need to be represented by someone other than the mother alone, who might have some conflict in terms of what is best. There are 3 general elements for a good consent: disclosure of information about the diagnosis, the treatment being recommended, as well as alternatives, demonstrated understanding of that information by the patient, and then a decision to authorize or refuse treatment. And it's important to know that, especially in the research setting, pregnant women are considered a vulnerable population, so there is heightened scrutiny of their decision to consent for a study. One reason is that this is usually an intervention like this offers risks to the mother for the potential benefit to the fetus, and oftentimes those benefits may be unknown in a study where you're looking at a novel intervention. As a result, it's really important to make sure there's adequate counseling about not only the risk, but what is unknown about the treatment, a demonstration of decision-making capacity, and it's important to ensure that there's a lack of coercion, either by members of the team or by other family members who may have divergent interests from what the mother is in her best interest. So our baby delivered at 35 weeks after undergoing amnio infusion. He was 2 kilograms at birth with normal APGARs of 8 and 9. He underwent a peritoneal dialysis catheter placement on day of life 2 and became hypotensive postoperatively, requiring ventilation and pressor support. Dialysis was initiated on day of life 1 with leakage and poor fluid exchange across the peritoneal membrane. And so he was started on continuous renal replacement as a bridge to peritoneal dialysis. He had a code at day of life 20 that was associated with clogging of the CRRT circuit, with a subsequent significant bleed from the line after anticoagulation. Peritoneal dialysis was restarted, but was complicated by peritonitis, and he remained ventilator dependent. So at this point, we had a discussion with the family about recommendations for comfort care. There was a concern that CRRT had not been a useful bridge. He was not able to start on peritoneal dialysis. And there was also concerns about prolonged CRRT due to the risk of blood exposure and potential future risk to his transplant eligibility. The parents continued to advocate for treatment. They felt that their baby had sort of been through these conditions where they were told their baby might not survive and had made it through. And there was quite a bit of unease within the team. There was a lot of differing opinions. There was not consensus on what the right thing to do would be in this case, largely because there's not a lot of data on what the right thing to do for babies like this are. And so we utilized a framework that's called the zone of periviability or parental discretion to help guide this case. And this has basically historically been based on decisions around intervention in babies that are preterm, so in that gestational age of viability between 22 and 26 weeks. There have been pushes sort of in the literature to expand this definition to consider prognosis-based areas where there might not be clear outcomes known. And it's a way to sort of look to say that the best interests of the child are best represented by the parents. And so in cases where the team may not agree on what the right outcome is, or there's no data on what the right decision would be, there should be deference to parents' sort of values and preferences. So after multiple discussions about potential risk, this baby continued or was restarted on CRRT. He successfully transitioned to peritoneal dialysis at 3 months of life and is now 18 months of life and undergoing transplant evaluation. So hopefully he will have a good outcome, and we'll find out what happens maybe the next time I give this talk. The next sort of diagnosis that I want to talk about in terms of these sort of lower tract anomalies is Eagle-Barrett syndrome. This occurs in about 1 in 25,000 males, and has been thought to be due to either differences in mesenchymal cell development and migration, in utero bladder obstruction, or also genetic causes, including HNF1 beta or trisomy conditions. The classic triad is absent abdominal musculature, bilateral intra-abdominal testes, and dilation of the urinary drainage system. About a third of these babies will die in the first month of life, primarily due to pulmonary complications. And this is partly due to hypoplasia, but also due to absent normal diaphragmatic support and abdominal muscular support for belly breathing in babies. And there's about up to a 50% risk of end-stage renal disease in these babies in childhood. In terms of prenatal intervention, there's very limited data on the efficacy of shunting. Small case series, including one from Texas Children's Hospital, suggests that there might be a decrease in at least 30-day mortality rate, with their series showing a 20% risk of mortality versus 32% in babies that were observed. But there have been case series that have demonstrated increased risk of shunt migration and bladder prolapse through the shunt insertion site that's likely due to the absence of abdominal musculature integrity. So this is a case of ours of a 28-year-old G5 para 4 woman who presented to our center at 21 weeks. She had a history of intravenous drug use and was in an unstable home situation. She was currently living in a sober house, and her other 4 children lived with maternal grandmother. As seen on the fetal MRI pictures here, the baby had bilateral hydroureteral nephrosis and megacystis, but had normal amniotic fluid levels. Amniocentesis was done, which showed a normal karyotype, and the baby delivered at 35 weeks. Postnatally, the baby had a rising creatinine that went from 1.4 to 3.89 from day of life 2 to day of life 10. And this was despite catheter placement and drainage. This is a picture of the baby's VCUG that was done on day of life 7. And he ultimately underwent a cutaneous loop ureterostomy with nadir of his creatinine at 0.9. He's currently age 4. His creatinine is 2, but he is CKD stage 4. And I think that's important to remember, both in children, especially in children that have abnormalities of their musculature. Creatinine may not be a good isolated representative metric for what overall kidney function would be. And so he's on the list for preemptive renal transplant now. And I think thinking about cases like this where there's a difficult social situation is important, because complex patients like these oftentimes require access to specialty centers for lifelong multidisciplinary care. And in situations such as where we live, where we have a large rural population in a large catchment area, it can sometimes be difficult to find adequate care locally in rural communities. As a result, families oftentimes need to relocate, which can lead to increased financial instability. And we know that having a complex care child can have a significant psychosocial burden on the family. Divorce rates are pretty high in these families, and siblings have an increased risk of anxiety, issues in school, as well as reduced quality of life. One of the other questions about kids in sort of both of these cases that I presented is these are babies that we sort of know will require transplantation relatively at an early age. There are limited organs for transplantation, and pediatric patients do have an advantage on the transplant list, but it's unknown what the long-term outcomes of these babies are, especially when they're requiring early therapies such as neonatal dialysis that may have unknown long-term risks. And so I think it's important as we're thinking about this to look at ways that we can ensure that we're providing adequate care and really expanding the way in which we offer care. And again, look at outcomes to make sure we can better counsel patients on the sort of risks and the outcomes of these less well-studied procedures. The third case that I wanted to present is a 36-year-old G1 para 0 female who had a female infant based on cell-free DNA. They were noted to have bilateral hydronephrosis and bladder dilation at 30 weeks with normal amniotic fluid levels. They had a screening fetal echocardiogram that was normal, which is pretty routine in our center to do a fetal echocardiogram. And the family was offered amniocentesis for further genetic testing and refused it. The baby delivered at 37 weeks. This was a postnatal ultrasound, which showed very minimal upper tract dilatation and a large bladder. And she was noted to require ventilatory support after birth. An echocardiogram done at that time showed pulmonary hypertension and a patent ductus arteriosus. And so I think especially when you're seeing abnormal cases or atypical cases such as megacystis in a female, it's important to consider atypical diagnoses. So there have been case reports of an Eagle-Barrett variant in girls. We also, which can be associated with genetic abnormalities, including HNF1 beta mutation. We also know that there are conditions such as megacystis microcolon intestinal hyperperistalsis syndrome associated with an ACTG2 mutation. There can be cloacal anomalies associated with megacystis. And finally, there's a diagnosis called multisystemic smooth muscle dysfunction, or MSMDS, associated with an ACTG2 mutation. So we recommend genetic testing in general in babies that have lower tract anomalies and try to really counsel for the potential benefits in babies that have atypical presentations like this one. This baby underwent postnatal testing and was found to have an ACTA2 mutation. And this is a relatively rare diagnosis that's associated with abnormalities of smooth muscle function based on autonomic nervous and innervation. And that affects the brain, it affects the eyes, it affects the cardiac system, the vascular system, the pulmonary system, the GI system, and the GU system. Our baby was actually underwent additional screening because of this diagnosis, and it was found to have moya-moya arteriopathy, radial gyration of the frontal lobes, as well as abnormalities here in the corpus callosum. And because of the concerns about sort of neurologic impairment, associated cardiac impairment and need for ventilatory support, after discussion with the family, the decision was made to proceed with comfort care. And so they took this baby home with them just a couple of weeks ago. The last thing that I want to talk about is what do you do in the baby that has in utero renal failure, and what are some of the things that we look for? So this is a baby that presented to our center at 29 weeks with anhydramnios and enlarged kidneys. This is the ultrasound. Baby was presumed to have a diagnosis of autosomal recessive polycystic kidney disease. Because they were 29 weeks, they were not eligible for in utero intervention, and the baby was born at 35 weeks. They underwent unilateral nephrectomy, and this is just a picture where you can see the right kidney in place and all the abdominal contents shifted to the left where the left kidney had been, just due to the mass effect of the kidney. And they had a dialysis catheter placed at that time. They were started initially on CRRT and then transitioned to peritoneal dialysis by day of life 10. And this baby had what we would consider a very good outcome. She was actually able to go home at about 6 months of age from the NICU. At 18 months, she underwent transplant evaluation, and a CT scan demonstrated evidence of multiple hepatic lesions in the right lobe. And so after multiple discussions with the family and our multidisciplinary team, our team recommended palliative care. There was concern about loss of dialysis access, concern about having hepatic surgery, and potentially requiring chemotherapy in a baby without kidneys, and potential concern about losing eligibility for transplantation because of this diagnosis. However, the family felt very strongly that they wanted to proceed with all treatment. And I think this sort of raises the question of how do you define futility in treatment when you counsel families? So, what do we consider futility in a case like this? Is it that there might be a 1 in 100 chance that this baby will do well and make it to transplant, a 1 in 1,000? And I think one of the concerns is we don't actually know what the outcome is. There's very few reports of success with early neonatal dialysis and long-term transplant outcomes. And there's even fewer reports. I could find no reports of a kid like this who was diagnosed with a malignancy or presumed malignancy that was then looking to undergo transplantation and was on dialysis as a neonate. This baby also felt that there was a real concern with the team not supporting their values. We had discussed comfort care at the time of their initial diagnosis, and they really felt that they had made all these tough decisions and they were on a path that they couldn't stop. And so because of that lack of trust in the family, it really led to sort of a conflict between the team and the family, and a concern about the team really having the best interest of the child in mind. So we chose to facilitate second opinions. They actually went to 5 other hospitals to get second opinions about whether comfort care was the right decision, and finally found a hospital that said that they would be willing to treat this baby. So the baby underwent a partial right hepatectomy for what was found to be hepatoblastoma. This was complicated by a chyle leak and positive margins on the resection specimen. She was transferred back to the Children's Hospital, developed sepsis and had a stroke, was able to get 4 cycles of chemotherapy before she had another code event and was in the PICU, but ultimately was able to make it back home. She's currently on peritoneal dialysis. She's now 4 years old and is being reevaluated for renal transplant after having recently had images to show that she is 2 years cancer-free. So I think I've talked hopefully about cases that will not be the norm of anybody else's practice. And I think one of the questions is how do you deal with some of these issues that we have sort of highlighted in terms of creating relationships with families, trying to deal with difficult decisions when there's no well-established outcome or well-established approach. So one of the things that we do is we have a very robust multidisciplinary team. We review all of our cases once a month and include ethics in that process up front to discuss options for care, things that we could have done better. And we really try to make sure that we have members of the team that will be treating the baby and making decisions prenatally that are the same members represented on our postnatal team. We've also really worked on standardizing our approach to how we counsel these families. We try to set expectations at the initial family meeting, both in terms of trying to elicit parent values and goals for care, and also to reinforce that this is an ongoing process with multiple difficult decision points. The decision is not for fetal intervention or not. It's to deal with issues where we don't know what the outcomes may be, and multiple times over not only the first year of life, but over the course of the life of these babies. We also try to make sure that there's continuity of our care team, both prenatally, postnatally in the NICU, in our congenital kidney anomalies clinic, and in our transplant program. And we really sort of try to explicitly state our goals to foster shared decision-making with kind of bidirectional communication, stopping when we're giving recommendations to ensure that families can contribute to the conversation meaningfully, transparency in what our goals are and what we do and don't know about care. And we hope that this then helps us to build a relationship of trust that can help to weather some of the disagreements that we know will happen either within the family, within the team, or between the family and the team. We also really try to make sure that we have an established framework to address issues that come up. This includes having actually a written ethical framework that includes values such as the fact that we're looking out for the best interest of the child in many of these decisions, that we utilize frameworks like the zone of parental discretion to make decisions. We have pre-established processes that are published, including a potentially non-beneficial intervention policy to deal with issues that might come around futility of care options, as well as clear criteria for involvement of ethics formally with the family after birth. And finally, we recognize that this is a very stressful situation for everybody involved in the decision. So we try to make sure that we identify family supports, whether those are friends, spouses, partners, extended family, and make sure they're part of these decision-making conversations if the family chooses to have them there. We've tried to establish processes to allow for second opinions when there just are disagreements that we can't sort of address and resolve. And we provide moral distress rounds for our team members to make sure that they're being supported in the care of patients that can oftentimes have difficult situations and difficult outcomes to deal with. So in conclusion, I think that there continues to be a role for fetal intervention, but what that role should be is impacted not only by the data that we're gaining from studies like the RAF trial, but also the legal milieu in which we practice. And I think it's going to be interesting to see how this shakes out and may lead to some pretty significant regional differences in care and standards of care because of legal limitations on what we can do. There's a lack of data on the outcomes of prenatal interventions and postnatal interventions in these babies that were considered to have previously lethal anomalies. And I think it's important for us as physicians to realize that intervention is the first of many steps that we take with these babies with unclear outcomes. And so trying to study this and capture data on these children is very important to help us to improve our own knowledge base of what might be best practice in the future. And finally, I think it's important to really invest time in developing relationships with families and relationships with the team, sort of across the lifespan of the child, and make sure that we're providing support for both the family and healthcare team members. So with that, I'd like to say thank you. Hopefully I've left enough time for questions. This is just sort of a list of all the members of our fetal GU anomalies working group. And this is a picture of my daughter, who is an IVF baby. And luckily I practice in a state where I didn't have to worry about what I did with my embryos. So with that being said, I'm happy to take any questions or comments that people have in the crowd.
Thanks. Great talk. Really interesting. Kind of anxiety provoking. Just out of curiosity, what are the maternal risks of some of those procedures like the amniocentesis and the shunting?
Well, I think there's some pretty significant risks surrounding like preterm labor, disruption of membranes. We have had mothers that have had issues with like hypertension after procedures, and it's hard to know if that's due to the procedure or due to anxiety and stress around the procedure. But putting moms under anesthesia, I think during pregnancy can be a risky thing as well. So we try to make sure that we're counseling about those kinds of issues, but a lot of them have to do around pregnancy loss and sort of complications related to that. We can also have issues in terms of like with things like exit procedures and things in terms of like integrity of the uterine wall and in future pregnancies. So there are some concerns. Yeah.
That was fantastic. Thank you for the talk, and obviously we're excited to hear other talks today. I'll ask you to put back on your medical and legal hats, since you wear so many different hats. In my introduction, I even failed to introduce your role in the ethics committees and bioethics, so many different perspectives. But you were talking about earlier kind of rights of the mother, obviously autonomy and rights of the fetus, and even the state like Colorado where you can do termination at any point. But I know your catchment area is huge. You go beyond 5 states, and there's always this now current legal concerns about what happens when you practice in one state versus the other, going back for theoretical prosecution.
So we're really lucky in some ways. So Colorado, I believe in March, basically passed a law that sort of establishes reproductive health equity and says that it's part of our state law that we offer care, including termination of pregnancy at any stage of the pregnancy if there's a risk to the health of the life of the mother, and electively, it was a decision that's made by the patient and their physician. It is not a decision where the state has significant regulation. And there also has been a recent executive order saying that we would not turn away people that needed reproductive health care in Colorado. Now, that being said, so our catchment area is Kansas, New Mexico, Nebraska, South Dakota, Wyoming, and Montana, as well as Colorado. And there are states that are pretty red in that area. So we've been lucky. Kansas had a constitutional amendment proposed that was voted down. There have been states, I believe, including Missouri, that have looked at potentially having the ability to prosecute across state lines. So if someone from Missouri, which we have had consults comes in for a prenatal intervention or a termination, they could actually be sued, and the doctor in Colorado could be sued. Those have not gone into effect yet. And there's a risk that would really interfere with interstate commerce laws. So I think it will be interesting to see how some of this sort of develops. But, I've been interested in not directly related to this on how the stop decision is impacting people's care. And I've been told that there are places in the country where you cannot mention termination at all. You cannot mention that, the sort of option of termination at any point in the pregnancy. Places, there've been sort of stories on the news and reports of people in places like Texas where they might have had a miscarriage and they're not being offered a D&C because the hospital is concerned that would be considered an abortion procedure, even though the pregnancy is not viable. And so I think there's going to be more of this to come. And unfortunately, this is my own bias, so I don't mean to offend people, they have other views, but I think the problem with the way this decision was made at the Supreme Court level is there's all these unintended consequences as to what happens to medical care, and nobody knows how those are going to play out. And my personal feeling is, even though I may have gone to school with a Supreme Court judge, they are not the people that know what to do in those situations. They don't know when is it a pregnancy viable or not. There are people in Congress that are like, an ectopic pregnancy is a viable pregnancy. You just have to have the egg moved. I've never seen that done in my practice. I'm not an OBGYN, but I'm pretty sure that doesn't exist currently. But that's what we're getting in terms of laws that are being written and the approach of people that are trying to regulate this. So more to come. It's definitely a bit of an unstable time.
Yeah, and I'll push you more into some controversy just to be mean. But I think that, even beyond that hot button topic, even in Connecticut, we're starting to see some of the legal fights between autonomy of parents and autonomy of the children, pediatric rights. And I think that really comes to play here. And obviously, again, balancing different states where you're having this attachment and people are traveling to come see you guys. How do you grapple? I mean, obviously, these are ethical issues.
Well, I think that one thing is that, first of all, it's important to understand and have as many conversations you have. It's a bit of a double-edged sword, right? You want to make sure people are having these discussions in a place where they feel supported. So we encourage grandma to come to the consult meeting, spouse or partner to come. But there are certainly situations where you can see that there might be people that have a certain view and are pushing decisions where the family might not really be comfortable with that. We have all of our family members, our moms, meet with a psychologist and a social worker independently. And when we're concerned about risk of coercion, we actually try to make sure that we're taking time. One of the nice things about this is that these fetal interventions don't have to happen the same day you have a family meeting. And so giving families a little bit of time to process. Anybody that's on the RAF trial has a secondary meeting with urology, nephrology, and our transplant surgeon to really help them understand what some of this process is. And one of the things we're working on is trying to see if we can have sort of patient support. So, have other families that have gone through this that can provide feedback. Because if you talk to families, it's a hard road, and there are families that would not have made the same decisions twice. The difficulty is this is a situation where people have a high risk of, not having that perfect baby that they were expecting, or losing a child in the first year of life. And so it's hard to, find whether or not those people are vulnerable to being in a situation where they're discussing it with other families. So that sort of is our approach to trying to make sure that the mom has support and is able to understand the decision that's happened. It's, I think, also important to know that there are very active Facebook groups around this. So bilateral renal agenesis. There's a woman who was a former representative in the House that had a baby with bilateral renal agenesis and got multiple opinions, ended up having serial amnion fusion and delivering at Johns Hopkins. And that baby was in the news in People magazine, that she got a kidney at age 2 and is doing well. And that's what led to the RAF trial, and I think has led to a lot of interest in this, is she's been a very vocal advocate and sort of tells families where to go. This is a center that will do this for you. Go to this center, not that center. And so there's a whole bunch of stuff around this that I don't think we as physicians necessarily know about in terms of information and misinformation that can oftentimes bias what people are asking for the minute they walk in the door before they've actually heard these conversations. And so I think in that situation, that element of time is even more important, because they're coming in with these preconceptions. And as I mentioned, we are very transparent about our outcomes. We say, this is the number of kids that we've treated with this, and these are our outcomes so far. We've had kids that die, within the first month of life, or that, are coming to transplant or not eligible for transplant because they have IVC thrombosis and SVC syndrome, and there's no place to put a kidney in. And so we try really hard to make sure people know this is a snapshot. We do not have enough data to make any meaningful conclusions yet, but this is our reality. These are the decisions families are facing, not just at 20 weeks gestation, but at 30-day, 1 year, 2 years of life.
Yes, fantastic talk. With such good information. In regards to long-term follow-up with these children, it's not just from a urologic standpoint, but do you have any data on their developmental?
So there is data on neurodevelopmental outcomes in kids with early end-stage renal disease, and there is developmental delay in that population. We in our clinic have we basically have created this sort of integrated program. So our fetal team for urology and nephrology is and psychology are the same team that sees patients in our congenital kidney anomalies clinic. So all those patients come to that clinic, and we have sort of established a data registry of all these patients. So we try to assess not only neurodevelopmental outcomes, but also like we utilize the impact on the family and sibling impact screening surveys to try to understand what the family burden is. That is a very nascent program, so I don't have great data from it yet, but we are trying to track those kids. And then luckily for us, our transplant surgeon, our nephrologist, and I end up seeing all these patients for transplant evaluation as well. So we're lucky to have a somewhat captive population to the extent possible that hopefully we'll have better long-term outcomes about that. What else?
I have a terrible question. That was the most clear explanation of fetal urologic anomalies I've ever seen. So thank you very much for putting that together.
Is this your only talk about fetal urologic anomalies?
I'm the surgical director of the fetal care center.
Okay.
So I've seen quite a few.
Okay, good.
So in terms of medical ethics, there are cases of, I'm swinging out of my league here, but there are children with leukemia, teenagers who don't want chemotherapy, and the state will kick the door down and say, that would be like letting someone jump off a building.
Yeah.
And so the state forces that patient to get chemotherapy. If the RAF trial converts 100% baby mortality to anything, 50% survival, 90% survival, could you picture a state that would kick the door down and force a pregnant woman to have fetal interventions to save the life?
It is interesting that you asked that, because there have actually been state case law about the state intervening for forcing care. So, in Florida, there have been states where there have been cases where the state has tried to mandate bed rest when a mom has refused bed rest for whatever reason, and has tried to imprison a mom for that. They've tried to mandate C-section and early delivery in a hospital when a mom had wanted a midwife or whatever. So there have been attempts to do that already that have not been successful. I think that the difficulty in this is there are so many unknowns, and I don't know if you may have more information. My understanding about the RAF trial is that there may be some data out this spring about sort of the initial outcomes, at least for bilateral renal agenesis. And I think that they are in some ways reflective of some of the things that are in my talk. And so I don't think we're at a place where that's what the outcome is going to be. And I think it would be very difficult to make the case unless there was 100% success and minimal risk of loss of the life of the mother or significant health concerns to the mother, where a state would intervene in that way. That being said, if you read the kind of concurring opinions in the Dobbs case, is really establishing this idea of fetal personhood under the law and of this sort of interest in fetal life that may potentially supersede maternal health. And so one of the things people are looking at is what is the imminence of the threat to the mother, and what does that have to be to allow for an intervention, right? So if you have kidney cancer, can you have surgery for that, even if it means you might lose a baby, if the mortality isn't 30-day mortality, it's 5-year mortality, right? So there's been questions about, can the state actually say you have to postpone care for breast cancer or whatever it might be that requires adjuvant therapy that affects the fetus if you're not going to be sort of risking death right away. Now, the flip side of that is when it comes to the miscarriage situation, the concern is of sepsis and like imminent maternal death. And yet there have been hospital systems that are like consulting with attorneys because they're afraid of having a DNC procedure on their board and being reported. In Texas, this is a state where citizens can make a claim and actually get paid for reporting people facilitating abortion. And so if you see a DNC on a board and somebody takes a picture of that and sends it in, hospital systems are concerned about their risk about this right now. So I do think there are areas where we are impacting potential care of the mother because of these concerns that are being raised about we're doing everything to preserve fetal life. Does that answer your question? Okay.
On the backs of that is 28-day survival adequate? Like, is that an outcome?
Well, I that's a whole different discussion. I didn't include discussions of ECMO and how somehow magically 28-day survival on ECMO was great, and then all of a sudden like 90-day survival on ECMO was not so good. It is a bit of an artificial outcome. Many of the cases that are presented in this space are by maternal fetal medicine and in these sort of OB neonatal literature, and I think that's why it's so important to look at longer term outcomes. Even the RAF trial, their secondary outcome is survival to transplant, but we don't know what the outcome is after transplant. And there are concerns about things like, again, vascular access and abdominal size and bilateral renal agenesis, that there might be decreased transplant sort of survival in those patients because they have comorbidities. And we've had multiple kids that have SVC syndrome that have bilateral renal agenesis and have been put on dialysis. So this is an issue that we're seeing. There may be other vascular anomalies, there may be unknown sort of secondary malignancies in the ARPKD case that you have to consider in terms of what is the global health and lifespan of this child. And do I put a kidney when they're limited in a 2-year-old that we know might have a risk of recurrent hepatoblastoma versus the 5-year-old that had normal urinary production and has congenital nephrotic syndrome that we have much better data on in terms of their longer term outcomes.
I think loss of a fetus is hard and detrimental to a family, but I think loss of a 2-year-old is probably worse than loss of a 10-year-old, even worse than
Yeah.
15. So these are bigger considerations, and that's where the preferences of the family.
Absolutely. And I think it's hard to know what that looks like when you're 20 weeks, right? So one of the things that we have found is that a lot of these families are like, I made the choice at 20 weeks to do everything I could. So like the first case, they made the choice at 19 weeks to have a shunt. And then they made the choice at 21 weeks to have amnio infusion. So they're not going to say no at 1 month when you're like, we've done everything, we can't take it away. They're like, we are committed to this course. You've told us before our baby could die, and they survived every time. They're the miracle baby, right? And yet when you look at the road sort of backwards in these situations, every family we've talked to is like, we did not know how hard this would be. We thought that we would get a kidney and our baby would be sort of normal and we wouldn't have to worry about anything anymore. And that is not the case. The intensity of care continues and in some ways gets even higher after you've had a transplant.
Is there like a survivorship or support group that you, I mean, it's maybe a little coercive, but
well, that's the thing. So we're trying to figure out a way to provide that, but we're concerned about, like, again, so many of these families are in very raw emotional places. So everyone that we've talked to would love to talk to another parent that's been through it, but it's finding parents that want to talk about it. We do have a support group in our K-Cut program though. So we do have families with posterior valves, prune-belly kids that they get together and they sort of get to know each other, know each other's kids. And that's been very successful. But that's kind of all comers. So we have, a much healthier, more survivable population there. Yes.
So Vijay, has anyone weighed the cost of taking care of these kids? Okay, so and the costs are very high, obviously, and some of these XBA means they can be $500,000 to $1 million for their nursery stay alone. Okay, and what is the impact to society? Okay, for caring for these children, because the majority of these kids are going to be essentially wards of the state and paid for by the state. Is it fair to essentially divert funds for the care of healthy children to the care of one this is a major ethical dilemma
Mhm.
in essence, that no one ever takes into account, right?
Yeah, I think it's a huge issue. So, RAPT covers the cost of prenatal intervention and care during the first 2 years of life. So that's covered by their research study. Our fetal center actually provides support for patients to relocate during the pregnancy. But the longer term risks are not known, right? A transplant alone is like $2.5 million, right? For the workup, the actual surgery, and like the first year of care. So when you think about, I mean, granted, how many babies are gonna be born and survive, but renal agenesis is not that uncommon. The numbers are similar to Eagle-Barrett syndrome, and we're seeing and we're intervening more on these kids that are anhydramniotic early. How many kids are we gonna be bringing to survivalship that may not ever be able to get a transplant, or that are taking transplants from other kids, right? We don't know the answer to that. I do think there's a pretty significant societal cost. Nobody has actually looked at that. I think this is a question of getting sort of this initial data on what is the success and what's the survivability of these diagnoses, and then looking at what the long-term cost
But that's gonna
is.
take you
It's going to take the rest of my
20 years.
career. Exactly.
30 years.
Yeah.
Okay, I mean, the cost aspect of it is very easy to figure out in a retrospective study. Okay.
Yeah.
And the impact of that needs to be measured when we have limited resources. Okay.
Yeah, absolutely.
And, the same thing goes with, grandma, getting everyone saying, oh, do everything for grandma, but if they have to pay for it, all of a sudden, oh, don't worry, you can take her off life support. So I think this is a major issue that needs to be answered moving forward as part of the whole question. Okay, because you do a transplant in a 2-year-old, you're doing another one at 22.
If you're
Okay.
lucky. Yeah.
All right, so now you're up to 5 million, and you were up a million on the, plus the fact that those patients who are SGA, many of them, I'd say probably 90% of them, are not going to be functional members of society. So they will never really, in essence, produce or provide anything to society from a point of view of work. Okay, so it gets very,
I hear your point for sure, Dr. Franco. I think that two things in there. One, that's one reason why we've tried to look at things like not only the cost to society, but also the cost of the family itself. Like I said, many of the time we tell families, one of you will probably not be working if you have a 2-family household, because it's a full-time job to take care of a kid like this. You may have to relocate from a place where you have a family support system to Denver because you need care. Things like peritoneal dialysis, they're coming in every week for evaluation initially. And during the transplant period, they're coming in very quickly. So there's huge costs in terms of family cohesion and in sort of burden on the family outside of the medical costs. The second thing, which you mentioned, is we expect a transplant to survive for 15 to 20 years. The minute a kid turns 18, if they haven't been listed, they lose their pediatric advantage. So that kid that turns 22 may not be getting a transplant at 22. They might be on dialysis for another 2 years. And we know that the mortality of dialysis is about 50%, right, after 5 years. So there's a chance that you're pushing sort of this, kicking this can down the road of making this hard decision about life another 20 years and investing a lot into that care. I think the difficulty is when you sort of look at the quality of life, there's all sorts of adjusted life units. There's like dollies and qualities and things to look at that. But I think that, that becomes very difficult to see this as purely an economic situation. And you talk to families, the baby that I presented with the ARPKD and the cancer, that family is so grateful to have that baby. And they're like, that we would do it all again, even though this was like a horrible course and we've been through so much. Our baby is incredible. The baby hasn't had a stroke. She's blind. She has hearing impairment. She does not have she's not reached normal neurodevelopmental milestones. And the mom is like, she smiles at me in the morning. I know that she's happy, and I would do everything I could to keep her alive. And so I think it's difficult. in these sort of emotional situations to really look at this as a purely economic decision. That being said, I don't think it's wrong to say, what is the cost that we're putting in versus the outcome? And what do those outcomes look like in terms of not only survivability, but quality of life? And I think that that's where looking at this from a number standpoint makes a little bit of sense. But the problem is in the literature, there's like a dozen case, maybe now 25 case reports. Every center has a different outcome. So how do you know what the survivability is? I can tell you what our center's outcomes are and what our approach is, because we've tried to standardize that based on the outcomes we have. But, there's a report from, Stanford of 2 kids, and both of their kids have made it to transplant. We don't know what happened after that. There's this, famous woman who's put her kid in People magazine, but there's not a lot of robust data on what the outcomes are in these kids. And so it's hard for me to counsel somebody, writ large based on, the 10 or so kids that we've seen in our practice prior to RAFT that we have 2-year or 3-year data on to say, what is the outcome? Because they might be willing to say, if you had an opportunity to do chemotherapy and get a 6-month survival benefit, many people would do that. And similarly, if I can say I can give you 6 months with your baby, some families would be willing to say, I'll take that risk. And then hopefully my baby will be the 1 in a million that makes it to 3, or the 1 in 12 in our practice that makes it to transplant.
I'm sure you're probably familiar already, but with Dr. Blake's work at CHOP and sort of the extracorporeal fetal environment, which has been successful in sheep. And I mean, he's thinking of that for children who are preterm and are delivered spontaneously at 24, 22 weeks. But if you would think about these children, they may benefit rather than trying to do amniotic fluid transfusions. If you could actually deliver them earlier, put them in an environment where they're surrounded by fluid, they may be, once that research continues, they may be a good treatment group for that.
Well, I think the problem is when it comes to sort of pulmonary development, the biggest window is 18 to 26 weeks, right? And so I think that one of the questions is, what is the survivability in a model like that at 18 weeks when you're most likely to get the benefit? I mean, the question will be, if you notice, every one of these babies delivered by about 35 weeks, like nobody went to term in our series of cases. And, that's the question. If I have a baby that I can get to 26 weeks, maybe there's a way to prolong that, because we know for dialysis purposes, a bigger baby, a healthier baby has fewer outcomes. We have certainly seen one reason we've shifted to a CRRT transition to PD model is we were having so many issues with dialysis catheters eroding through the abdominal wall, or leaks, or infections, that we were like, these are not babies that heal normally when they're 35 weeks and 2 kilos. And so we've had more success by utilizing a hemo bridge, especially with things like carpe diem and aqueducts that allow for smaller blood volume and blood exposure in these babies.